Ladies and gentlemen, please welcome Autodesk Strategic Industry Relations, Phil Bernstein.
Good morning, everyone. This is one of the innovation forums. It's the fourth, I think, of six, or the fifth of sixth. When we conceived the innovation forums, we saw them as an opportunity to take the intellectual energy and some of the types of folks who come to Autodesk University and use that energy to explore a different set of ideas. And one of the things that we've been very interested in here is the question of how different kinds of designers explore a similar problem from different perspectives, and how their worldviews, their frames of reference, their methodologies might address a very similar problem and attack it. And so what we're going to do today in the Innovation Forum, and you can see here that we're going to have some visual documentation on the screen going on at the same time. Our artists will be here documenting this. What we're going to explore here is the question of what happens when you take a similar design objective, and in this case, it's how do you address the global problem of delivering healthcare services in places where it is difficult to receive them. And we're going to look at how that problem might be explored by the disciplines that are present here at AU: architecture, infrastructure, manufacturing, and media and entertainment. And really what we're interested in is understanding methodologies and understanding best practices, but what we're really interested in here is generating some new and provocative ideas and engaging really in a dialogue about what those ideas might look like. And so what we've done a little interesting science experiment. We found 4 really, really strong designers, thinkers, who operate in these 4 realms. We gave them a very vague assignment. Here's your challenge. Think about how you might use your own processes, your own sensibilities, your own frames of reference, and whatever technologies you think are appropriate, to how you might solve the problem, the challenge of delivering healthcare services in whatever form you think is appropriate to folks who have a hard time receiving those kinds of services. And what we've really done here is we've set the problem up with 2 components. One is we want to use the enormous experience and brains and insights of these 4 very talented folks that we've invited to speak to you today. But the other is we wanted to run an experiment. We wanted to see if they could engage with their own communities using methodologies of crowdsourcing to see whether or not social media could assist or accelerate or somehow reframe the problem in an interesting way. So what each of these folks is going to do today is come up here and talk to you about the ideas that they've had about this particular problem set, and they're pretty interesting and they're extremely diverse, and I think you'll find this to be a very provocative discussion. They'll talk a little bit about how they collected insight, how they applied their own personal experiences and sensibilities, and then how they used their industry ideas as a refraction, as an approach for solving this really significant social problem, which is how do you get healthcare to people who have a hard time actually receiving it. So, and I would encourage you to try to stay through this discussion because we do have a little interesting twist, a little bit of a surprise for you at the end that will allow you to participate in this discussion directly, thanks to some of the technology that we have. So with that, we're going to have a series of 4 short presentations followed by an interactive discussion to think about this really, really interesting problem. So here are the folks that you're going to be seeing today, and I'll ask each one of these folks to come up as I introduce them. First is Dr. Mishkin Ingawale. Mishkin has an amazing background. He's an electrical engineer. He has an MBA. He has a PhD. He wrote his PhD on Wikipedia, if I'm not mistaken. Welcome, Mishkin. Mishkin's going to look at the problem of how you might deliver healthcare from the point of view of a manufacturer. Mishkin runs a really interesting company called Biosense. He'll describe that a little bit. They are working on manufactured products that can actually address this particular problem of healthcare. Our second speaker, a fellow architect, Liz Ogbu. Liz did her undergraduate work at Wellesley and then went to a small emerging architecture school in Cambridge, Massachusetts, called Harvard Graduate School of Design. Some of you know how I feel about those guys. Liz is actually an expert in a couple of the issues about the relationship between social strategies and how architecture affects social strategies. Third up today is Dr. Alistair McDonald. Alistair's with Balfour Beatty. He's their Director of Strategic Innovation. Alistair has a PhD from the University of Bristol and does a lot of work on the intersection of social and physical infrastructure. And finally, Professor Marla Schweppe. Marla is a professor at the Ross Trester Institute of Technology, where she invented and now runs several of the curricula there in media and games and entertainment. So we're going to have 4 10-minute conversations, followed by some short conversation. Then we'll have a bit of a panel discussion, and then we'll have a little bit of way for the audience to participate and maybe extend this discussion into the future. So, Mishkin, I think you're up first, my friend.
All right.
Enjoy.
Okay, thanks, Phil. Am I audible? Great. So, like Phil was mentioning, I run a medical device company in Mumbai, based in Mumbai. We build devices that can do tests at less than 10 rupees a test. That's less than 20 US cents a test. So, an example would be a device like this, which we are commercializing right now in rural clinics in India, where you would test for anemia non-invasively, so without pricking. Looks like a pulse oximeter. It's as simple and inexpensive as a pulse oximeter. So this is the kind of things I'm talking about, where, before doing this, there's a huge string of failures. I'm known as the guy who failed 32 times, because I'm really good at failure. So all of our failures have been instrumental in figuring out, how this one thing should work, and then how it should go out. So this is the kind of thing which I believe is really important, which exists here. I studied in Boston, so I know the best practices of schools there and of industries there. So that's what I'm trying to figure out. How can we actually, that's the question I ask my universe, the people I know. So these include engineering students like myself 5 years ago. These include young entrepreneurs like myself today. These include experienced entrepreneurs, many of them basking in post-VC glows with cash in the bank. Fund managers, government bureaucrats, and of course the consumers, the clinics. So this is, I got a very interesting set of responses. People were, engineers told me what engineers tell me. I want to build gizmos, gadgets, new sensors, Android applications, iPhone applications. It should, do this, real-time streaming, blah, 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 blah. Okay, so very, very interesting stuff, though. Similarly, young entrepreneurs had Android as one of their big sort of keywords which kept coming up. But interestingly, the experienced guys, people who had seen and actually faced a lot of the problems in the field, they told me something slightly different. They told me, you need a systematic solution. Each idea is just a Band-Aid. You need a solution that will develop the local ecosystem of technology startups in affordable healthcare. That's what they were telling me. Prototyping and medical technology innovation centers. And a little bit of, the doctors and the consumers, the clinics, they were just interested in, give me a product that works, that is cheap, inexpensive, and reliable, accurate, and so forth. Give me TouchB. Give me non-invasive glucose. I said, OK, fine. NGOs said, forget about toys, forget about gizmos. We want political solutions. My friends on Facebook, they didn't say anything. They just posted pictures of their babies. But anyway, the consensus from all this discussions, wide discussions, was that, A, ideas are plenty. Many people have many ideas. But the real problem in developing countries is the next step. How do you validate that idea? How do you build a prototype? How do you fail the prototype? Prove how it works, prove how it doesn't work. Generate that data. That's when VCs can step in and start funding these kind of things. And that's really how it's worked in the US, how the whole medical device, huge companies have come up. And the real gap is not so much in the ideas. It's not so much in the market. It's the connection between the idea and the prototype, which can then gain a traction in the funding circles and get the hockey stick kind of funding and growth, which happens with any good startup. So that said, here's the idea, right? The basic idea I started with was then not a gizmo. Let's narrow down the question, frame the right question. The right question was, what will make a difference in the product startup ecosystem for affordable healthcare? Narrow it down further. How to address this little gap, this chasm between the product idea and the proof of concept prototype? One step further, basically, how do I make the idea hockey stick worthy? How do I make it fundable? And well, this was the basic idea. And I know how I did it in the US. When I was in the US, I would take an idea and prototype it. And here, of course, Autodesk has its very interesting solution. I used this and other solutions. I used, post an idea on, say, Express 3D or any kind of web 3D prototyping store. It comes back to you in a few days. Wonderful, right? Then you can test it, physically run it through a battery of tests. It works, it doesn't work, can it be improved? If it can actually solve the problem, you convince a VC who will, with a hockey stick much like this in an Excel file and a PowerPoint, very slick PowerPoint deck, and then if you manage to actually make a difference in a consumer's life, more consumers come in, and you have that's how the ecosystem of medical devices happens. Unfortunately, in India and in places like India, this step is really, really, really pathetically bad. I've faced a huge challenge in prototyping, 3D printing in India. It's a huge problem. And what that does is essentially, it tells me that there has to be some systematic solution. There has to be something systematic which can be done. And here's what the big idea is for me. The big idea is really very simple. It's as trivial as a 3D printer. Now, I know for sure that technology alone will fail. It's not going to solve the problem. So my little universe, the crowd I talked to, they came up with an idea. They kept basically refining this, playing with the idea, and said that, hey, technology is all good and doing well. Let's try to come out with something which is affordable, available, accessible, and appropriate for the kind of setting I'm talking about. So the idea, which eventually, after a couple of iterations, this is what they told me would be interesting to try out, is a 3D printer, not a new technology, proven, reliable, boring 3D printer, right? Take that and figure out the right kind of 3D model around it, like Snapfish or Express 3D, some kind of service which will, A, allow non-technical people, doctors, engineers who are not really product designers, send in their concepts, send in their drawings, even paper drawings in like an engineering drawing, physically made with pencil and on a chart paper, and have at the back end some kind of wiki kind of model, a crowdsourcing model, which would, like Wikipedia does, refine, edit, ensure there is quality control, ensure that this right kind of editorial quality system is in place to refine those ideas and make them ready to print. That's the basic concept which they came up with. So I said, hey, this is interesting. Let me see how this can work. So back of the envelope calculations. In India, the home of the back office, the home of the BPO, let's put the BPO to good use. Let's hire 3D designers in Bangalore, very cheap, 5 of them for $30,000 a year, and community of enthusiasts, like Thingiverse. I was talking to Bree here. He was mentioning interesting plays in medical devices. So use the crowd, use the back office, and generate a tremendous support system behind the 3D printer, which will be able to essentially fine-tune designs by non-technical people into products which can be then pitched to VCs. Hungry MBAs are going to solve the problem, not do-gooders. That's my personal take on it. Yeah, so I did my PhD on Wikipedia, so I call these two sections tonks and twiddlers. We need tonks and twiddlers to take ideas and refine them and make them something which can be prototyped. Yeah? Have some university set up in India or in the US which can afford support, space, all kinds of infrastructure help. All the material cost by the entrepreneur. But that still means it's very, very cheap, less than $50 a kilogram. And yeah, any profit from this venture, it's fed back to the venture. So that's the idea. What I believe, sincerely, what this will do, basically this very simple idea, which is not rocket science, it's something which has been proven in the US. If you apply this with a slightly tweaked business model, what this will do, it will give a fighting chance to startups. The ecosystem has to develop locally. That's the strong feedback I got. That you have to have people who are closest to the problem, people who have faced the problem. In my case, I saw people dying before I could actually figure out the real problem. And this is the kind of thing which I think will really make a huge impact. I was just trying to figure out the scale of what could happen. These are some big numbers. More than 900,000 today doctors, more than 1 million nurses, more than 500,000 engineers per year graduating in India alone. Forget the rest of Asia, forget Africa. Just in India, these are the huge numbers. These people know the problem. They face it every day. I walked into a PHC, a primary health center, and I saw the problem. Now, if you give these huge this quantity of people tools to fix their own problems, you can really change the world. That's what I think. I was lucky. I was in the US. I knew these tools. I could work with these tools. But these guys here, I think you can really make a huge difference. And I read an article in The Economist about 3D printing, and I saw the word difference engine, the play on Charles Babbage and all this, what exclusion kind of thing. But very literally, I think that if 3D printing a model emerges in developing countries with the right kind of wiki kind of support cast, you would really, literally, this would be a difference engine. That's what the big idea from my universe is. And of course, I do believe that it's not going to be a do-gooder enterprise. I believe that it has to be sustainable. It will have a hockey stick of its own. It will break even. Once the capital cost has been invested, you would have, hopefully, you could have this project can build a proper plan to make that kind of hockey stick happen, and in the next 3 years, break even and do a lot of good things. That's about it. Thank you.
OK, so wait, don't go away yet. I want to ask you a couple questions here. So as I understand it, this idea, we're going to call this idea twonks and twiddlers bring you a difference engine.
Perfect.
Right? And so, you were saying at dinner last night you were a big Star Trek fan, so we expected you to show up here with like a proposal for an Indian medical tricorder. But you're not actually proposing that at all. What you're saying is there's a platform that can acknowledge, what was it? One of your friends said toys are useless, and you said technology will fail?
Technology will fail.
So if we were to take this project forward a little bit, what would you see as the next step?
The next step for this is make a business plan, go to a university in India, say, hey, I want free space. I know, for example, IIT Bombay or Indian Institute of Management would be happy to give free space. Set up a facility like this, link up with Bray, with Think Universe. You have now you have space, you have the infrastructure, the printer, and you have Bree's whole twonks and twiddlers available there.
Twonks and twiddlers,
yeah,
yes.
So that's the 3-step process, and set this up. Give it a couple of years to find its feet. With a multidisciplinary support cast here as well. This needs media and marketing. This needs to have a standardized operations backend. This needs to be the message to reach every engineering college, every medical college, and every doctor in India. That this is something like this. Make it happen. You can become rich. And
what did you say last night? That one of your, when you were doing your PhD, one of your professors said that if you had $1 billion, you couldn't get Wikipedia?
Yes, yes. So there's a wonderful quote. I did my PhD on how Wikipedia works. So there's a wonderful quote, I really love this, by Mitch Kapoor, I think the Lotus founder. He said that in early 2000, if somebody had proposed to give $1 billion to an entrepreneur to set up something better, always better and much always relevant than Britannica, nobody would have been able to do it. It's not possible for $1 billion. It's only possible for free.
So Wikipedia is only possible for free.
That's right.
Really great. Thank you, Michigan.
Thank you.
OK. All right, that's idea number 1. Twonks and twiddlers and the difference engine. OK, next up is Liz Ogbu, and she's going to talk a little bit about reimagining patient experience.
Thank you very much, Phil. Good morning, everyone. I wanted to start off just by asking 2 questions. The first is, how many of you have access to reliable health care? Meaning either you're covered by insurance, or if you ever got sick, you could go somewhere and get access to care easily and affordably. It's a little hard to see with the lights, but a good number of you out there. Second question, how many of you have heard of the term pop-up health clinic?
Okay. I see one hand.
Not that many people.
Not too many. 3, maybe?
All right. Hopefully, by the time I finish this piece, more hands will be able to raise up with that. So I found this challenge to be super interesting, and I do a lot of work all over the world, particularly in developing countries, but I was really interested in talking about the healthcare challenge that exists here in the US, and the fact that there was a huge percentage of people who were actually without adequate healthcare. So in the US, the way the system works is that there is health insurance that allows you to actually seek out care. And there are over 50 million people in the US who are what we call uninsured, meaning that they actually cannot get access to health care. And this is a significant problem. And in recent years, what's happened is that we've had pop-up health clinics spring up, and they're essentially run by NGOs. They last over a period of 3 to 5 days. They often occur in large-scale facilities like sports arenas, and they do everything from medical to dental to vision. And for many people, this may be the only time that they see a doctor in a year, or more often than not, you hear people saying, this is the first time I've seen a doctor in 5 years. So there's a significant problem, and while these pop-up health clinics have helped to fill the gap, as you can see from this image, it's a really ad hoc operation. And so I was really curious about how could we talk about improving the patient experience in this capacity. So I'm an architect, or trained as an architect, and I'm used to working collaboratively. And so this was a little bit of a challenge of how do you take that from a physical collaboration to a virtual collaboration. So the platform that I initially ended up using was something called HCD Connect, which is a fairly new platform that was introduced by IDEO.org to allow people who are practitioners of human-centered design to come together and share best practices and be able to ask questions of one another. And I thought, hey, this is great. I've got people who this would totally be in their wheelhouse. And so I posted it, and it was a little bit of a failure. I had over 1,000 people look at it, but it had very few people actually giving me suggestions, which led to me actually having to broaden things out a little bit. And as Michigan said, I also had to reframe the question. And so instead of asking people how we might reimagine the patient health experience at pop-up clinics in the US, I had to ask, well, what have you seen around the world that's innovative with pop-ups, particularly in healthcare? And also ask people, tell me about your own health experiences. What has been positive, and more importantly, maybe what has been negative, and through that, extrapolate ways that we could begin to apply innovations here. And so from that broadening, we then started to move back to a more narrow focus and eventually returning to looking at this in the UX context and how we could possibly innovate. So some consistent themes that came up, no matter where in the world people were in terms of these pop-up clinics, was transparency. So there's often a really bad communication system in terms of helping the patients understand what is going on when they're waiting in line, or even when they're actually communicating with the doctor. Many people don't actually know how to talk to their doctor or get the information that they need. And when the doctor is giving them information, they don't necessarily always understand it. There's also an issue of comfort, which is probably understandable given that these are pretty ad hoc operations. So they're not really set for the experience, they're more about the care. And so that's a serious issue that, like, if you don't feel comfortable, then, and health is something that's key to your body, this can actually turn into a bad experience. Speed, of course, if you're waiting in line with 4,000 to 10,000 people, nothing moves fast. And then there's also access and mobility. These clinics may pop up for once a year, they may be once every couple of years, but what happens in the gap in between that? So there was some definitely room for improvement here. So what became clear to me is that while initially I thought as an architect I might go in and it might be about designing something that could be put in a large-scale arena, what actually became clear is that there were problems at 2 different levels. There was one that had to do with the entire system itself of pop-up clinics and dealing with things of how do we actually improve the time and location in which these things are occurring so they actually really do fill this gap a little bit more substantially. And then even an idea of institutionalizing pop-ups. So if you think of the informal market, it may have started off as an original stand that somebody set up to sell things, but then over time, it actually becomes institutionalized in that you know that you can always go there and be able to buy it, and a whole marketplace might be created. And you might go there and shop as opposed to going to a brick and mortar store. So could we talk about the same thing here and not consider them consistently as this ad hoc operation? So the solution that I'm proposing is in 2 parts. One is the system scale solution. So it's actually talking about how do we move away from these large-scale pop-ups to a more distributed system, where we do smaller clinics that are placed in facilities that are actually located within these poor communities, such as retail stores or vacant storefronts. They can still be on a temporary basis, although for sustainability's sake, they may not be 3 to 5 days. They may be more like 1 to 3 months. But they can actually, by getting out there more often, tackle the system at a bigger level than just doing one large pop-up clinic once a year. The other part of the problem was the actual experience of the patient when they're going through this. And this is dealing with everything from that whole problem of not quite understanding how to talk to your doctor, so how could we demystify the process, to taking advantage of existing technology. There's technology in these platforms is kind of non-existent. And so what was interesting is that a lot of the suggestions that I got from people had to do with mHealth, which is mobile health, which has been catching on like wildfire in the developing world, because in many of those countries, people completely skipped the whole landline piece and went straight to cell phone technology. And as a result, there are huge rates of cell phone ownership. And so a lot of people who do work in developing countries are now pushing things like mobile banking and mobile healthcare, being able to understand whether the drug you purchase is actually fake, all through a cell phone. And so what's interesting is that here in the US, we do have kind of electronic access to health records and mobile health platforms, but they generally exist at the middle and the upper class. There's very few that's targeted at lower income populations. And it's interesting that one study by the Pew Research Center actually found 75% of poor adults here in the US actually own a cell phone. So the potential exists to actually tap into this market. So the second part of my solution is a human scale solution, which talks about us moving away from, as you can see, this is people lining up. They're all using paper to actually register for this clinic, and they will use paper to pass on the recommendations of what people are supposed to do going from here. And so I'm proposing that we actually move to a digital platform, both at the point of care when these patients are coming in, but also moving forward, using the cell phone as a way to actually communicate with the patients once they leave, whether it's distributing additional health information or getting them back in for follow-up care. So again, this kind of exists as a two-part solution. At the point of care, which is sort of this lower quadrant here, it's this idea of institutionalizing pop-ups, moving away from these large-scale operations to smaller and more nimble operations. And at the other end, when it comes to like maintenance and how do you keep this going on, actually introducing mobile health technology for low-income populations. And when you can see, this is actually tapping into a lot of different groups. There's a very cross-disciplinary nature about this, whether it's bringing engineers, industrial designers, architects, doctors, to look at how could you design that kit of parts that could be deployed at some of these existing locations to form these small-scale pop-up clinics. Or on the other hand, and in terms of mobile health, how do we bring interaction designers, public health folks, industrial designers, to actually create these mobile platforms that can keep in contact with the patients long after they've left the health clinic. And so I put this quote on the bottom. It's a William Gibson quote, "The future is already here, it's just unevenly distributed." It's not like I'm proposing technology that we will not see until 2025 or 2050. All of these components actually exist. They've not been combined in this way or brought to this target population. And so really the solution is about taking a look at the landscape and bringing these things together to actually effectively impact a group of people who desperately need it but aren't getting access to that right now. So thank you.
Thanks, Liz. So I'm really interested, as a fellow architect, that you chose not to show us a building design, but instead a systems strategy that, as I understand it, leverages existing infrastructure. You would negotiate this deal with Walmart, and you would use people's existing cell phones. And so it's actually a system design solution rather than a physical solution. Where did that idea come from? I mean,
well, so I initially thought it was going to be a building design solution, and then as I got suggestions from the crowd, basically, what became really clear is that there were a lot of interesting things happening with the technology that already existed. It just had not been deployed in this particular sector yet. And so sometimes I think the greatest innovations can come not from inventing something new, but recognizing what you have and figuring new ways to actually amplify the impact of that.
so if you were going to take this idea forward, what would happen next?
So when it comes to institutionalizing the pop-ups, I think it's, you could look at places like Walmart and approach their corporate social responsibility departments and get a hold of some of these NGOs that are already doing these remote clinics, like RAM, which was one of the ones that I showed a lot of pictures from, or even something like Kaiser.
Or MSF.
Or MSF.
Yeah.
And partner up together. And actually, there's a whole concept of prototype to learn. So actually getting 5 Walmart stores and running these clinics over a period of time and seeing how they go. From the mobile health, some of this technology already exists. IDEO and Frog Design have both done some really interesting things around this. And then also there are a lot of people who are doing work in the developing world who are actually based here and bringing them together and testing out some of these platforms for a cell phone here.
So Walmart and cell phones,
yeah.
The infrastructure of the solution. Great. Thank you very much.
Thank you.
Okay, so from architecture, we go to infrastructure, and our next speaker is Dr. Alistair MacDonald from Balfour Beatty. Alistair?
Thank you, Phil. Good morning, everybody, and thank you for taking the time to listen to us this morning. What I want to do is try and present to you how I think the infrastructure solution can bring together the ideas of some of my colleagues here in order to close the circle on healthcare in underserved areas. The first thing I wanted to do really was to take the temperature of the patient. And in the same way as my colleagues had, I used my network to try and connect in, find out how that patient was doing. And I've ranked the effectiveness here of the different techniques I used. I think really the lesson I learned was that if you want to develop a solution, you actually need the one-to-one contact, that iteration over the course of maybe a phone call or, in fact, in some cases, sort of face-to-face. But that in terms of getting a broad view and getting some insights into what's going on in the world, that actually the LinkedIn site was pretty useful. Unfortunately, Twitter and email didn't give me the sort of responses I was looking for, and perhaps for some of you that won't be a surprise given how much email there is flying around these days. For me, there are really two things that we need to do, two things we need to address. One is how do we cure the symptoms of this issue up front? So how do we deal with the healthcare issues right now in the front place? But then how do we also treat the cause, the underlying issues to underserved areas, healthcare in those underserved areas? When I went back to my network, I got an awful lot of solutions. There were transport solutions, there were temporary solutions, service solutions through, say, the Red Cross, or telemedicine in technology solutions. But underneath all of these, there was an underlying issue. And I picked Africa, because the WHO's identified that as the least well-served part of the world in terms of healthcare. And unsurprisingly, the major problem in Africa is funding. So a lot of poverty and a lack of funding. And a really quite scary statistic is that it takes about $44 per capita per person to get a minimum level of health care. And less than 50% of African countries are spending that much money. That's, for me, I think, a really scary statistic. So as a good engineer, the first thing I did was think about the players. And I've categorized them into these four areas for simplicity. And I wanted to look at what their desires were and what their ailments were. So let me just pick up on a couple here. In terms of the people, they are indeed looking for a basic level of health care, but there's not very much infrastructure and definitely a low level of education around health. The government is looking for economic growth in most cases, but finds they have little or no funding and, in fact, very little investment know-how as well. The investors, unsurprisingly, well, they're looking for a good return, and in some instances, they're looking to secure resources in Africa. But they face an uncertain policy environment, and they also have execution concerns, so they're worried about the delivery of these projects that they're investing in. The suppliers, well, they're about profit, they're about efficient delivery, but they face a real issue of corruption and a lack of labor. So my solution is really in three parts. Firstly, it's about understanding the virtuous circles that align the desires of each of our players. Secondly, it's about accessing the knowledge that exists in the developed world and sharing that with the players I've outlined here so that we can overcome the vicious circles that are causing these ailments. And finally, it's using my colleagues here today and also their industries in order to make those messages, those knowledge shares, more impactful. So let's have a quick look at that in a little bit more detail. The generalist's view, if you like, understanding the virtual circles that are going to align the desires of our stakeholders. If we look at our investor, say China or in India, they're looking to secure resources in Africa. And what this means is it leads to an investment in infrastructure, which suppliers can provide. The result of an investment in infrastructure is, of course, an upskilling or, an increasing in the social infrastructure that's available, which will help to address these healthcare issues. That leads to economic growth, and closing the circle, the economic growth causes an increase in demand for resources, and therefore an increased desire to secure these resources. Now, this is a virtuous circle. It's not the virtuous circle, it's just one of many. But if we can find out what these virtuous circles are and start putting them in place, I really believe we can align the desires and begin to create this sort of success. So let's look at the second part, around taking the knowledge that exists in the developed world and sharing it with the developing. This is the specialist's view, if you like, overcoming the vicious circles that are causing the ailments. So these are a couple of the ailments I highlighted in the earlier slide. And what I'm going to do is I'm going to give you sort of about 20 seconds or so of silence, which I'm sure you'll be glad about. Just have a quick read through the sort of vicious circles that we're seeing and that came through from my checks with my network. So my belief is that we can start to break these vicious circles down. And the way we can do that is by taking the knowledge that exists in our organizations and our governments in the developed world and by sharing it in three very key areas. First of all, in terms of policy provision and advice, what are the models and the contracts that we should be using in the developed world to ensure more efficient delivery? What is the education and health provision knowledge that we can be moving from our part of the world to the developing world? And finally, how can we ensure that the construction and maintenance expertise is effectively communicated so that we bring down the costs and increase the safety of the development of the social infrastructure that will underpin an improvement in healthcare? If I take a look at how we might do this, first of all, in terms of policy provision and advice, well, for me, this is about bringing the three Ps, the PPP, private-public partnership models, the integrated delivery design models, etc., the procurement and investment advice that governments need to ensure that when the investor brings in big cash for infrastructure investment, it is funneled into social infrastructure as well as into the resource infrastructure that they're needing to secure their resources. Secondly, taking our experience from the UK, in my case, we work very closely with our local communities in order to ensure that there are small and medium-sized enterprises working on our projects, that the local labor force is upskilled through apprenticeships. And if we could take that, plug it into the idea of the pop-up clinic, which is pervasive in the developing world, plug those two together, we would not only achieve healthcare with the pop-up clinic, we would also be able to educate local labor force in order to upskill them and provide them with increased knowledge of the health needs of their communities. And finally, what I think we need to do as well is to take the BIM, the modular construction knowledge we have, the life cycle maintenance knowledge we have, and share that as well in order to bring down the cost of developing this social infrastructure. So what's the final part? What sort of pulls this all together? Well, this is my pitch, really, for us to work very closely together as industries, really to get at that design across boundaries working. Because I think there's a holistic treatment there that brings together the generalist view and the specialist view and helps us to design across boundaries. And let me give you sort of three examples of where I think we can be doing this. My media and entertainment colleagues undoubtedly can help me because I'm an engineer and I am terrible at communicating. If my knowledge sharing is going to be impactful, I'm going to need compelling and shared messages that we can put out to the communities in which we're working. In terms of my product manufacturing colleague, we need to take those factory-based manufacturing techniques, which are all about driving down cost and increasing safety, and we need to bring those to site. And in terms of my building design colleague, we need to ensure that we've got a blueprint for a low-cost, sustainable social infrastructure design. So, in summary, there are really three parts to my solution. First of all, it's about understanding how we align the desires of our stakeholders so we create those virtuous circles. Secondly, it's about how do we take the knowledge that we've developed over years within the developed world and move that into the developing world in order to improve upon, reduce the cost of, increase the safety of the development of social infrastructure that will underpin our improvement of healthcare. And finally, how do we work across boundaries with my colleagues here and their industries in order to ensure those costs are as low as they possibly can be so that social infrastructure can develop? Thank you very much.
Thanks, Alistair. I'll take that. So I want to make sure I'm following this completely. What you're really talking about is a design of social infrastructure rather than physical infrastructure? Is that the proposal?
Sorry, social infrastructure in my industry are hospitals, schools. So it wouldn't be in terms of, how we interact socially. It'd be in terms of the infrastructure that helps communities to thrive.
So it's a strategy for sharing knowledge in these stacks.
Indeed.
To create that kind of infrastructure.
That's correct.
What you're suggesting.
But also about aligning the desires of our various stakeholders, because I think without that, you aren't going to get the stakeholder buy-in, the engagement that will take a solution like this forward.
And you're arguing that you need all these guys as well to sell.
Yeah,
so you're dependent on them.
I am completely dependent on them.
So if we took this project forward, the first thing you'd do is partner up with these guys, or what happens if we were to take this project forward?
You've seen my slides before.
I've seen them a couple of times, yeah.
Yeah, no, indeed. I mean, the first thing is to engage much more closely with, we had a great dinner last night where I found out that Liz is actually an expert in Africa, and she offered to take my slides over for me and complete my presentation. So it would be great to engage. The product design piece, I think, fits absolutely beautifully and neatly into its idea of a pop-up clinic, and ensuring we've got the right tools in order to efficiently deliver that healthcare. And as I said, I am absolutely a terrible communicator, and unfortunately so is most of my industry. We're very good at building great structures and great infrastructure, but we're not very good at telling anyone about how good we are at doing it. So it would be great to call on our media and entertainment colleagues in order to help us make those messages, that knowledge sharing, more compelling.
I think you did okay. Thanks, Alistair. Appreciate it.
Thank you.
Okay. All right, so Marla's up next, and Marla is one of the world's leaders in the integration of physical and the digital, and she's going to talk to you a little bit about her idea for crowdsourcing healthcare solutions using an M&E point of view.
Thanks, Phil. So I come from a little different perspective because I really don't have a lot of expertise in healthcare in any way, shape, or form. We do games and movies and interactive installations and theater and lots of other things. So what we did was a crowdsourcing of people involved in media and entertainment coming up with ideas for what we could do to help healthcare in rural underserved populations. So what I did is I set up a page on Facebook and enticed people to participate. So the purple dot on the bottom is my posts that got it started, and then I had to attract people's attention to the page, and you can see that I started getting feedback after a week or so. So the proposals all had something to do with media and entertainment, most of them. What we came up with was an idea for a doctor in a box, and I know that there are some other examples of mobile healthcare systems, but they usually have healthcare professionals resident in those trailers. And we were trying to look for a way to have media and entertainment make it possible not to have so much staff required to travel with this type of facility. So this is our reception room where you do intakes or schedule people for appointments. And we thought there might be several kinds of appointments that you would need. Maybe an appointment with a doctor. Maybe you need an appointment to talk to someone about health insurance. But one single facility potentially could serve all of those needs, especially when you have a smaller population in a rural area that's far from larger medical facilities. It also turns out that a neighbor of mine has a device not too dissimilar from the kinds of things that Michigan is making, which is about this big, and with one drop of blood, it can test for 20 different diseases. So we thought, well, there's our lab, our portable lab. So it would take somebody who could be trained to use that lab and somebody who could keep track of appointments in the sort of office part of the facility. So there's not a lot of media and entertainment in that space except for a system of keeping track of the appointments and communicating. So the second room in the space is, and again, it could be a trailer or it could be, like Liz suggests, in an existing space like a Walmart or any place that happens to be available. A lot of small towns don't have Walmart, but there might be a open space, you know, in the downtown area or something like that. And instead of having a physical doctor there, you do video conferencing with a doctor. Now, obviously, if you have a really serious disease, like you're having a heart attack or something like that, that's not going to solve it. But the majority of the time when you go to the doctor, it's for other kinds of things that are not so desperately life-threatening. So the ideas would be to have this room where you could either meet with a doctor or you could meet with an insurance agent to set up your insurance now that you're required to have insurance. But do it virtually so that the doctor doesn't have to travel and you don't have to travel. Because travel, a lot of times for people who are poorer, who have to travel on buses, is very, very time consuming, and you may have to take time off from your job. Or if you live in a more remote town, my grandmother, for example, lived in a town where she had to travel 75 miles to go to the doctor. So this would save that time in a lot of circumstances. So this is our sort of big picture of the doctor in the box, and that's pieces of it. But then, inspired by Sumitra Mitra, I don't remember how to pronounce his first name, we decided that I had shown his TED Talk to my classes, and so some of the kids thought this would be a really great idea, is on the end of this Doctor in the Box building, we would put a computer built into the wall at child height. And it would have like a flow chart for if you have questions about your health, you'd say, oh, I've got this bump on my arm, what does that mean? And it would ask questions like, well, does it look like this or does it look like this? And you would get an idea of whether you should go to the doctor about it or if it's just something you should put some medicine on, so that you would be able to make some healthcare decisions without going to the doctor. I have a similar thing in my home healthcare book, okay? But we thought maybe adults might want to like use the system too, so we put a bench in there that they can sit on to get down to kid height. And then the other thought was to put some games on the same computer that would be about healthcare, so that they could play games, for example, where they could choose to eat different kinds of food and see how it affects their long-term health. And the challenge would be to eat well so that you live long, or something along those lines. We've also been doing a lot of projecting on unusual things, like the outsides of buildings. And so we thought, well, when the box is closed up, we have a great projection surface on the outside of the building. What could we do with that? And the answer was Ivy, the investigator. Ivy is a middle school girl. She is a whiz at medical stuff. She likes to investigate problems and try to figure out. She's kind of like the middle school Dr. House, you know. She likes to figure out what's going wrong. And sort of the idea is that we might inspire some of the kids to spend enough time working on the computer to learn about healthcare issues, and that we could also show other this is our primary idea for this, but other kinds of videos about healthy eating and that kind of things, or that Ivy, the investigator, could do investigations about how do you eat healthily so that you live longer and you don't have to go to the doctor and you don't get sick. For really small towns, we thought, well, we can just put it on wheels, because maybe some towns you'd need a facility 7 days a week, and other towns, maybe they're small enough where you might want to move it around so the facility is available 1 day a week or 2 days a week, so that the same resource could be shared by several towns. So that's our basic idea. And I think, like many of my colleagues have said, like the machines that Michigan is designing and inventing would be great additions to the one that my neighbor makes. And certainly we don't know too much about Africa. We know more about our surroundings in upstate New York and smaller towns in the poorer neighborhoods. So she could certainly help us with that, and Alistair could certainly help us with organizing the whole thing. So.
Okay, thanks, Marla.
Yep.
So, as I understand this, this is kind of it's a small piece of architecture bathed in media, right? And so your proposal is that your team would invent these various kinds of games and other kinds of interactions. Talk a little bit about how you might develop Ivy, and if this project were to go forward, what would happen next?
We already built Ivy on a grant from the Center for Women in Technology.
Oh, so Ivy's already done? Good to know.
We have the character, yeah. So we'd write stories relative to healthcare, and then create some animation. And we'd also create the games and the interactive piece for the computer on the end. And I suppose, ideally, we'd be able to create a little structure or find a place to put the actual structure as well. I do a lot of set design. We wouldn't do it as an architect. I'd do it more like a theatrical person, you know, and test it out.
We'll have to talk to the licensing authorities about that, but that's okay. Yeah.
We'd have to test it out somehow. You know, so.
Great. Thank you.
Thank you.
Okay. Let's thank each of these guys for these provocative presentations, and now we're going to have a short conversation before we do a little audience interaction. So I want to just make an observation before I ask you guys a couple of questions here. I think it's really interesting. When we designed this forum, being tool makers, I think we assumed that each of you was going to think about how our tools might be used to do the thing that you do. So Marla, we figured you would make a game, and Alistair, we thought you'd make a road or a dam or a water treatment plant. Liz, you certainly were going to make a building because you're an architect. And Michigan, you were going to make another one of those cool gadgets that you're working on. But instead, Michigan proposed a business model. Liz proposed a systems design. Alistair proposed a knowledge management strategy. And the only building I got out of this deal as an architect was from the media and entertainment person. So what I'd like to first ask, and start with you, Michigan, what is it about the way we frame the question and your particular attitude that made you work almost orthogonally to the way we conceive this problem?
Yeah, it's pretty interesting that you mentioned it, you know, summarized it this way. What I found is that a very strong, so typically I would reach out to NGOs or people who had spent like 20 years of their lives in these communities dealing with these problems. And over the course of their time, they have sort of developed this strong resistance to any technology which is imposed on them. Yeah. However good or bad it is. Some of them are very good, some of them are very bad. There's a whole spectrum of gadgets and cool toys which are given to them. And they I don't know, some of it, like I said, some of it might be really applicable, but they want to control what they do. They think they know what they're doing, because they have essentially the relationships, they have the community understanding. And a little bit, I think, what you guys mentioned, right? Some of these, I mean, not everything is high tech. Many of the innovations I've seen in the field are really super simple. Like, I mean, just to give an example, a doctor I visited recently at a clinic, he had, realized that all this, they had an ERP they had a mobile-based ERP. It never worked because the telecom network never worked very reliably in that area. So he eventually just made a color coding system of his own, It was beautiful even from a mathematical point of view, how he had assigned different color codes. So even the illiterate people could start using it. Now, this was an innovation.
Yeah.
It's very bottoms up in response to a problem. So I think that's what my thinking was. My bias is that, hey, let's act, but not in a top-down way. Let's act in a way where we give the right support and tools to communities who are at the front, where they are directly facing the problem. That's my sort of general gist of how the conversations even unfolded with these 20-odd people I talked to.
And I thought it was very interesting the way Liz and Alistair's projects had these funny entanglements that we didn't expect. So Alistair, you proposed work in Africa where Liz happens to be, a world-acknowledged expert. And Liz, you proposed really the use of an existing infrastructure to solve an architectural problem. So I'd like to hear you two guys critique each other's ideas, and I'd love to hear your respective responses to what you thought about each other's ideas. It's not a competition, at least not yet.
Do you want to start?
Sure. I think it's interesting, although location or geographically, we were in two different places, we were kind of at the same place in terms of the actual solution required knitting together these various sectors to come together and talk about how to get to a common solution. In some ways, I think we actually satisfied the directive of the panel in that your expectations for us were more in our disciplinary silos, and our responses were more about moving across boundaries.
Agree.
Because I think what we're realizing is that trying to solve these problems from within our disciplinary silos is part of what the bigger problem is, that we've been unable to innovate and actually adequately address the solutions that are needed, because if we only see in tunnel vision, we only know what's in front of us. And oftentimes it requires looking beyond that to understand. So I would say with yours, Alistair, I thought that you were making that reach out, that one of the biggest problems that's happening now in Africa is that if you do things in these silos, you can't get anywhere. And some of the biggest innovations that we're seeing is when all of a sudden the mobile phone companies are talking to the healthcare providers and saying, how do we reach out to the people who really need it? Because everybody has a cell phone, and we can't get physically to every place that needs to be there. It's sort of similar to what Marla had mentioned with some of the rural communities.
So what would you recommend that Alistair do to improve his project? Don't worry, Alistair, you're going to get a chance to make the same recommendation for Liz.
I think it would be piggybacking on some of the groups that are already there. It seems like what you're proposing is actually an amplification of things that have started to happen. And so whether it's taking somebody like MSF, or I'm totally running a blank on some of the various health groups that are active, but there are several ones that are like on the ground doing quick and dirty stuff, and what you're sort of proposing is extrapolating up to the next level and adding a kind of official layer to it and a connection. And I think that there's some really rich opportunities. I know Rwanda just launched a huge thing around doing a connection between the healthcare sector, architects, and engineers, and so bringing that kind of thinking there, I think, would be really helpful.
Sure. So, Alistair, what would you recommend that Liz do to accelerate progress on her project?
Well, I mean, what I really liked was the idea of taking existing technologies, plugging them together in order to come up with a solution. I thought that was, I work a lot with new ideas, and getting new ideas to commercialized and brought to market and successfully used is really, really tough. And by using those things that are already in the market, already in use, and by combining them, I think you can convince people to invest in that sort of thing a lot more easily. In terms of a recommendation, that's a tough one. I think it's a pretty good solution. I guess the thing that we need to understand better is maybe a next step would be to look at surveying particularly the people that experience these pop-up clinics to understand what is it that they actually feel. We've probably, I think it's not unfair to say that we've polled a group of people that have really not that great an idea about the issues that are being faced in these.
So the crowdsourcing strategy.
That's it, because our networks aren't necessarily based in Africa or based in communities within underserved communities within America. We need to get really down and survey and understand what is the problems of those people that are facing these. So I think probably that would be the first step to make sure the design of the system was right.
Marla, your crowdsourcing exercise seemed to be more effective than others. Do you think why is that? Was it because you drew the question more narrowly, or? you have a lot more power in your network.
I
you're just cooler than the rest of these guys?
pestered people till they did something.
So in order to really make crowdsourcing successful, you have to pester people.
Well, I think it either has to be, people don't know it's there unless you're at a, I mean, it was on Facebook. Maybe it wasn't the best choice of place to put it. There's some places that do crowdsourcing all the time. And if I'd gone to one of those places, I didn't know that much about crowdsourcing when I started. If I'd gone to one of those places, maybe people would have been looking to post their opinions about things. I don't know.
I don't know.
You know?
In Michigan, if you were going to ask Marla to help you out with your proposal, what might you do?
So as you might have sometimes noticed, I'm quite pathetic at communication. So even at the half the battle is actually lost in the first 10 seconds when you're dealing with, you might have noticed, right, with any, the first impression you'll make with the customer will essentially, I think, so in your vision of effectively communicating even tough concepts visually with the appropriate medium, with the appropriate message, that would be awesome. If it's possible, in fact, any of our solutions, right? That convincing the person that it's something which you which is benefit you. That's if that can incorporate in any of our basically ideas, that would be awesome.
Because I think it was interesting that it was only Marla's project that had a kind of virtual environment or even a vaguely technological component. I mean, you were gonna buy a 3D printer, but it wasn't very important in your strategy. Would you agree?
The importance of?
The 3D printer.
Yes, so what my basic idea was, let's not ask the poor to bear the cost of innovation. So in this case, experimenting with, say, new technologies is something which typically I've seen happen, say, in Boston or in San Francisco or somewhere like that, right? So a new technology should not, my thinking was, let the technology be stable. Too many moving parts will just not get us anywhere. For a tangible output, we need a stable technology and then innovate specifically on parts of the model which will achieve direct impact, measurable. So we should be able to quantify. This is the number of people affected. This is the, there are metrics like gears and other impact measurement metrics. So it should have that kind of professionalism behind it. That was my...
But I thought it was really interesting, right? The ratio of doctors to engineers in India is there's 2 doctors for every 1 engineer, meaning there's this huge intellectual resource. So he's built this gadget designed to collect as much of that insight as possible, but not build a ton of research infrastructure, if that makes sense.
I thought it was interesting that you also talked about the schools as being platforms for innovation, that's the point where you could start to get some of these groups to come together, is actually at the point of their training, so that becomes fundamental to how they understand how they practice, which is, I think, a super interesting idea.
Absolutely. This is one of the sad things I've seen. When I was in India doing my undergrad, I was never exposed to these problems. I was exposed to them in Boston. Okay, then when I went back and say, hey, that's what they were talking about, and it's real, people are dying, and there you have the solution. So I was lucky enough to sort of, both worlds are there, one leg here, one leg there, like you said. But the silo in India is like very bad. An engineer never actually sees the health worker or the patient, and the doctor never actually walks into an engineering lab.
Yeah. I think what I'm learning from this last conversation is that, and probably maybe is the reason that a number of our solutions weren't technology driven, is that probably in an innovation space we don't spend enough time looking at the overlap between the social system and the technology system. We dive straight into developing the really cool piece of kit often, rather than thinking, okay, how does this impact, how does this actually affect the social system that we're going to introduce it to? And that might be a reason why technologies aren't always as impactful as we'd hope.
Yeah, I mean, we're going to get through this whole session without mentioning a single product, which is probably going to get me fired, but I think it's been good in terms of the overall discussion.
Wasn't that at the bottom of the brief? Don't mention
products. So do we, I guess we can take a couple minutes and take some questions from the audience if there are any, and then we're going to do a little bit of audience participation. So if there are folks in the audience that might want to ask one of these guys a question before we involve you in this discussion, please raise your hand and shout out your question for them. We can't see very well up here, but yeah, in the back.
Do you want him to have a mic?
Wait,
There's a mic
is there
over
a hand
here.
on or come on up closer and we'll repeat your question.
Shout at us.
Yeah, there aren't that many of us in here, so it's okay.
One
Yeah.
Can you kind of take that to the next level where it becomes more of something that's not laughing about somebody falling down the stairs, but actually doing something?
So the question was, why was the social networking, crowdsourcing aspect of the defining the problem space so difficult, so weak, and I think in our we all would sort of agree, but also how can we use the efficacy of the internet to drive investigation of these kinds of questions rather than watching cat videos or posting people falling down the stairs. Anybody have any thoughts about that?
Can I
Please.
give it a shot? We were discussing yesterday with Alistair, in fact, and I think I had a chance to be there when the local motors model and presentation was taking place, right? So here's what I think. Right? There's three things which the crowd needs to become active. Number one is a well-defined problem. So a broad problem will get many diverse responses, but a very narrow, well-defined, structured problem, you can start activating the right set of people and the responses. Two, it has to be something very time-bound. In this case, I think the fault is ours. We were not putting enough pressure on the crowd. This is the time by which you should generate ideas. And three, it's something which they should directly relate to in their lives. For example, if I ask somebody how to use photoplethysmography to start measuring bilirubin, I'll get, huh? And they'll, so it has to be a very something which they can directly relate to. If I ask this question, I'm sure to medical device product designers here, I'm sure I'll get very good answers. So finding the right fit between the community and the question, I think, would be.
Marla?
Well, I was just going to say, I mostly know people who are involved in media and entertainment, and so when I ask them about healthcare problems in rural and underserved populations, they say, I don't know anything about that. And yet, part of what crowdsourcing is about is getting ideas from people who may not be experts in the area. They might have just a different perspective.
Right.
And it seems to me one place where it might be really useful, but it might not work on a computer because people might not have access to it, is within the populations where they don't have enough health care. Then they won't have enough health care for the same reasons they don't have other kinds of information available to them. I think education is a huge part of getting good health care, because I think a lot of people, just from personal experience within my family, who don't avail themselves of health care, don't because they live in a small town and they don't like going to the doctor, They won't go unless somebody makes them. My grandfather, for example, was having a heart attack, and we had to take him to the hospital. He wasn't interested in going. He didn't grow up around health care,
Yeah.
So.
Now, Alistair, you took a very engineering approach to this by systematically categorizing all of your crowdsourcing failures and ranking them.
Yeah,
so,
absolutely. I think in answer to the first part of your question, that the size of the community makes a big difference. I mean, there is just no doubt that 29 people is not going to give you a broad spectrum of views. Even if they are distributed all around the world, you get a little bit of diversity, but you don't get that breadth. I think so that possibly is how we accelerate, as we expand those communities. And I think Michigan makes some very good points about the fact that you need to be quite specific about what you're asking so that people can engage in that. The other thing I learned really though was, and comes back to my experience of working, is that actually to really get to grips with a problem and to get underneath the problem, you actually need some interaction around it, either face-to-face or over a phone. And the problem I found with social media is that you write a comment, you go away, you don't think about it for another 10 days, or if you're a really active person, 30 minutes, but effectively you've stopped thinking about it, then you come back and think about it again. So it's useful for answering yes/no questions often, but certainly my experience of it has been that it's really difficult to get under the skin.
Yeah, Liz, and then we'll
I mean, I would totally agree with that. I think a lot of social media is based on one-way communication. Either somebody's posting a story, or you're responding to the story, or you're looking at a video. There's nothing that's about an actual dialogue, or very little that's about a dialogue, and we're not trained yet to view social media as a dialogue platform, not just a one-way platform. So I think that figuring reducing the barriers, which I think is what we all ended up doing, whether it was reframing the question or figuring out more intimate settings in which to launch this, ended up being a way that we got more people to engage. But I think the natural inclination that we saw initially was to look and maybe click a like or forward it on to friends, but not necessarily for people themselves to contribute anything.
Okay, great. Thanks very much. All right, before everybody runs off, we would like to do one more thing. We set this problem up today not just to explore the question in an intellectual way, but we're actually quite interested in seeing whether some of these ideas have some traction. And so what we have decided to do as Autodesk is we're going to make a $50,000 grant available to one of these folks to take their project, either as a nonprofit or with their students or a group of students, forward past this presentation and on to do work during the course of the next year, and then bring the results of that work back at AU next year. But we, Autodesk, are not going to make this decision. You guys are. So if everybody can whip out their phone, everybody takes out their smartphone, we're just going to do a little quick in-audience polling, and you can signal your interest. These are all four of these projects are really, really interesting. Michigan's innovation platform. Liz is leveraging existing infrastructure project. Alistair's knowledge sharing strategy for breaking the circles. And Marla's media enhanced dock in the box project. Each one of these ideas is really interesting, and take a minute and think about this, and then when you text that code, IFAABBCC, to 37607, in just a second we'll bring up the results, and this small but very dedicated group of audience members is going to fund some research that will go on for the next year. So we'll give you a minute to do that. Need the Jeopardy music on now, right? And we might even finish early for lunch.
I noticed there isn't a vote for all option there.
Well, I thought yours was the vote for all option. All right, so it looks like Liz's project is the one that is going to get funded. And Liz, I hope that you will leverage the knowledge and insight of your colleagues here and perhaps form them as an advisory team we take forward. And let's congratulate our speakers and thank them. And Liz, we'll look forward to seeing how your project goes next year.
Thank you.
Thank you, everyone.